Hey guys, this is Greg with Medical Muscle. In this video, I'm going to talk about the surgery rotation, the core rotation in surgery. This is part of a series where I talk about all the core rotations, so let's get started. It's a 12-week rotation, and I have to say it's one of the most important rotations that you will do because surgery is the second most important topic in step 2, just behind internal medicine. You'll see the most amount of questions coming from surgery. So, how my rotation went. The first 4 weeks was colorectal and oncology. Those are the first 4 weeks. Half of my group did that and the other half did vascular. We didn't have a choice on that, it was random. So during that 4 weeks, we would start our day, well, we would round at 6 a.m., which means I needed to get to the hospital before that to pre-round on those patients. So I would see, 3 to 5 patients that I saw the day before or a few days before. And I would just go up and, get there at 5:30, maybe 5:15, get to the hospital, go and check their chart really quick if there was any updates, go and talk with the patient really quick, see how their pain is, see if they've defecated or if they are farting. It's important to know, especially with all surgical specialties, to see if the patient is passing gas and the opiates are not slowing their digestion too much. You don't want a small bowel obstruction. You're going to push on their belly, make sure they're not distended, things like that. So I would try to get all that done and get back to the surgical lounge to meet up for rounds at 6 o'clock. And then so as we're rushing around the hospital, seeing up to like 35, 40 patients, it was insane. We'd rush around, go quickly, see everybody. While we were walking, I would just give the residents, the chief resident, or whoever was the lead on that team, any updates that I noticed from, talking with the patient, so that when they go see them, they know what kind of questions they need to ask. After rounds, we would go to our cases. So I was in a group of, I think it was like 6 students, and each of us would divvy up the cases on what we had to see for that day. For me, I preferred the later stuff. That was just me. Just so I had some time to in the morning, but it was relatively chill after that. You're doing any like little detail work that some of the residents need, like if they need you to go up and see a patient, go see them. But for the most part, I would have a lot of time to study. Surgery, I was surprised at how much time I had to study. There was tons. Between cases, I could easily knock out 10 to 20 UL questions, okay? Before the case, I would always get to the waiting room really early, go introduce myself to the patient, tell them what my role was and how I was going to assist. I never was kicked out of a case. People were very friendly and willing to have a student participate. Then I would go to the OR early. This is very important. Get to the OR early. And you want to get your glove size and all your gowns. Make sure that the tech has all your stuff ready. Here's a pro tip, okay? You can help your resident, you can help your busy resident by getting their gloves and their gown ready as well, okay? So that, because there's different sizes for gloves, you need to know those, and just have that. More pro tips when it comes to the OR, okay? Always get 2 gloves, because if you prick your finger or you cut a glove open, you have that added protection. And always wear eye protection. Always wear some kind of face protection, because blood will splatter on your face, oftentimes, okay? I've got to say that. And most importantly, wear crummy shoes. I'm going to tell you that in another story later in this video. Okay, wear shoes that can get dirty. Okay, so that was colorectal. Usually we were done, no later than 5 p.m. So 5:30 to 5 p.m. Not the worst that it could be, but hey, that's what it was. All right, the next 4 weeks that I had was Gen Surge. Pretty similar time, similar schedule. Everything else was the same except what the procedures were. We had, appendectomies, cholecystectomies, some bariatric stuff, just a whole range of things. Hernia repair, robotics. We had a lot of robotics. Just a little note on the oncology, there was also the breast surgeries, which I noticed that, especially with mastectomies and things like that, breast cancer, students got a lot more opportunities to be first assist because the procedures weren't not as complicated. So usually the residents preferred to not go to those and go to the more complicated, colorectal surgeries. And the breast surgeon needed help, and a student was there to hold things open for them. So I thought that was a lot of fun. It was very interesting. Gen Surge, same thing, nothing crazy. Then I went into 2 weeks of trauma. Trauma was very different than what I thought it would be. Basically, we would wait in a small room, and any calls through the overhead, or the beepers, we would run down to the trauma bay in the emergency department and get ready for the patient. Most of the traumas that we saw were falls, people just falling down a flight of stairs, cracking their face, all that kind of stuff. A lot of questions on the shelf exam that had to do with trauma. So knowing what the right procedure is very important. When do you do a fast exam? When do you do a CT? When is it okay to move into a CT? Things like that. I thought it was helpful to have a pair of shears during trauma, because that's how you can help as a student. You can run down and help cut off the patient's clothes. You have to get their clothes off. Sometimes they've broken multiple bones. There's a lot of blood, and you need to get the patient exposed to get them into the CT or whatever, get them into surgery as soon as possible. So you need to cut their clothes off really fast. Getting a good pair of scissors is really helpful. Having that on hand. Maybe carrying a face shield too would be smart. Okay. But I could say in general, trauma was pretty chill. We had to do the same thing, get there early. Same kind of hours as all the other, parts of surgery. Get there early, do your pre-round. Then we did rounds on the trauma patients, things like that. Nothing too out of the ordinary, except that there weren't really that many OR cases, I have to say. It was mostly just rushing down to the emergency room, and then, you just have someone with a bruised eye or, a big old, abrasion on their face, but they end up being fine. But, you still have to go down just in case. The worst ones I saw in trauma were scooter accidents and construction accidents. Those are the worst. Big falls, falling from a height. A little scary. Okay, so the next week I had 1 week of anesthesia. So luckily we got 1 week. It was fantastic. Anesthesia was incredibly interesting. I got to intubate a lot of patients. The anesthesiologists were really cool. I know that's not surgery, but that's when we got to do that part of the rotation. The hours were very light. Jeez, we would start. I had to be there, just when the case started. So if the case started at 9, that's when I needed to be at my first case. Obviously I had to be there early to go introduce myself to the patient, but that's when I got to sleep in. And then usually the anesthesiologist would have me intubate, and they say, "Peace out, brother. Get the heck out of here." So, once that's done, I was done for the day. For how many cases they had or how long they wanted me. I think I learned a lot about some of the medications that anesthesiologists use. So it was very interesting. And then the last week I had was an elective week. This is going to probably depend on what your hospital offers. We had ENT, orthopedics, plastics, neurosurgery, and transplant. Those were the options that you could choose. I think plastics was on there. I think. I chose ENT. The hours were really relaxed. The procedures really, pretty complex, really small, small areas that they're working in. It's like the face and neck. It's pretty incredible. But I've heard some great things about orthopedics. I know students that did that. You end up doing a lot of MSK, physicals on people. You're assessing, what their range of motion is, things like that. Transplant, I heard, was also pretty interesting. So if you get the opportunity, that would be neat. Other than that, throughout all the rotations, I would assist in help cleaning the wounds for patients or changing bandages. That's a role that students do. I think it was a smart thing to always carry bandages and gauze and tape and things like that in your scrubs. Always a good idea. Have the scissors. That's helpful. Flushes. Have flushes in your on your person at all times. That's very helpful. So for the extra stuff on top of that, we were required to do either two weekend shifts or a 24-hour shift. We got a choice. So I picked the 24-hour shift because I was already at the hospital on Friday and wanted to just stay the night there and then, leave in the morning. Very interesting. I got to see the most. I noticed that the students that did the overnight saw the craziest stuff and got to do the most because there was no other students there. Okay, so you get this opportunity to be more of a participant than other days. So about my shoe story, I was working with a surgeon. There was a patient that had some fluid in their abdomen. It had spilled over the little curtain thing that we had, and I felt something warm on my foot. And I noticed that it was dumping all over the shoes of myself and the attending. And this is on the 24-hour shift, and it was kind of early in the night. And I was like, oh my Lord. So I had to throw my sock away, and then I used those heavy-duty antiseptic wipes. They're so toxic, the ones that you have to put on gloves because it's so toxic. And I disinfected my shoe, and I just went without a sock for the rest of the night. So that was an interesting situation. The shoe that I had to wipe clean ended up smelling better than the shoe that I hadn't cleaned. So that was interesting. So definitely wear crummy shoes. If you can bring another pair, it's very helpful. Just a huge pro tip. And obviously, yes, wear protection on your eyes. I remember doing a breast surgery, and we were they were wiping down the surface, and just some fluid flicked up on my face, and luckily I could see it on the glass that it didn't get in my eye. So important. Okay. Other than that, work on your knots, work on, being able to tie, because as a student, you are definitely going to be asked to close portholes or any kind of incisions. That's a student role. What else? Know how to hold traction. Don't get in the way. Get you only help when you think it's appropriate. That's a little hard, I think, for a lot of people to get down. But you help when you can. It's better to stay away if you can. Be ready to answer anatomical questions. How people say pimped. You'll definitely be asked that by certain attendings. They're going to ask you some serious details about what's the anatomy as you're going through. For the shelf, I have to say UWorld was very light. I think there's only 600 or something questions. It's super, there's barely any questions for a 12-week rotation. I think PEDS had the same amount of questions, and that's only 6 weeks. So what that means is that you should supplement your question bank. That means if you did 20 a day, you would get done with it in half, in 6 weeks or something like that. So I would say get Amboss. That's when I got Amboss, to supplement that rotation, to get more questions in. You just don't have enough. And a lot of the questions in the shelf and on STEP are really what's the next best step in this situation? It's not about the procedures, the actual act of surgery. It's everything else that's on top of that. When to use fluids, what kind of presses are you going to use? When do you do, the patient has an ulcer on their toe, do you chop it off or do you try to save it? Frostbite questions, trauma questions, patient fell, or one of their favorites is like person hits their abdomen with a steering wheel. What do you have to look for? Is it a splenic rupture? Is it a pancreatic rupture? Is it duodenal rupture? Things like that. They love those types of questions. So very much like, what is the next best step in that situation? Okay. All right, guys. I hope this was good. I really would appreciate it if you guys like and subscribe to this video. There's many more to come.